let them all in.
Open when complete. I'll mute myself. Isn't it? Or is it here?
The unique role that pathology plays in the science of healing is now at the tipping point, reshaping the future of pathology itself using 21st century tools and technology combined with big data analytics. These changes will help pathologists diagnose diseases with greater speed and precision than ever before, arming them with technology-based insights that will help identify diseases faster, more accurately, and at a lower cost. Ushering in a new era where genomics, syndromic panels, and liquid chromatography reduce recovery time and exponentially increase the success rate of recovery. A future where the world is connected and distances are shrunk to deliver better diagnostic results. Welcome to that future. A future that is inspired by geography and united by technology. Welcome to Newburgh, a whole new world.
Okay. Shall we start, sir?
Yes.
Okay. A very good evening to all. I, on behalf of Chandigarh chapter of Society of Fetal Medicine, extend a very warm welcome to the faculty, panelists, and the attending delegates to today's webinar on septal defects and conotruncal anomalies, as we understand that the prenatal diagnosis of these anomalies could be extremely challenging at times. I take this opportunity to welcome Dr. Ashok Khurana, a true academician, teacher par excellence, mentor, guide, visionary, and above all, a wonderful human being. He's the main driving force behind the inception of Society of Fetal Medicine India, which has today attained a global platform. Sir has been the past president of the Society of Fetal Medicine. The prime objective of the Society of Fetal Medicine is to promote and expand education and research in the field of fetal medicine and try and provide every fetus an optimal outcome. With these words, I would request Dr. Ashok Khurana to take over the today's proceedings and formally introduce our guest faculty, Dr. Orhan Uzun. Dr. Khurana, please.
Thank you, Lord Buns, and congratulations for putting together such a nice program. I'd like to congratulate you and Dr. P Singh for doing this for us. And at the outset, thank you, Adi, for many years ago, introducing me to one of the finest human beings I've ever met. Orhan Uzun is a fetal and pediatric cardiologist. He has origins in Turkey and has since moved on after finishing his medical studies there to be in Wales, where he's done some fabulous work. He's a highly decorated and popular teacher, a wonderful researcher, and you will be very impressed with his actual CV. But I know that what's far more fascinating for you is to know that he has actually founded and led the Welsh pediatric and Welsh fetal cardiovascular networks, as well as the Welsh heart families and the Welsh patient parent research group under the auspices of the BHF. And that has truly been something fantastic to be able to achieve, where you actually reach out to the people who reach us the most and make sure that every fetus and every child that needs us has the right psychological environment to get the optimal outcome. Thank you very much, Orhan Uzun, for joining us today. May I also remind everybody that you have a fabulous background in fetal and childhood arrhythmias. We're not going to discuss those today, but hopefully we hope that you will one day guide us through arrhythmias. We firmly believe we don't know anything about arrhythmias. I mean, we found it very difficult to learn about them, but that's for another evening. And I'm going to convince you that it's worth teaching us. And I'd also like people to know about your wonderful work in electrophysiology, and also how you have done so much original work in fetal echocardiography and making sure that there is also a better understanding of maternal cardiovascular health, which is now achieving center stage, because we finally understand that it underlies growth restriction and preeclampsia as well. We have, of course, a very, very impressive list of research works from you. But what we really want to hear about, without further ado, is your fantastic talk today on the evaluation and assessment of septal defects, atrioventricular septal defects and ventricular septal defects. And thanks once again for joining us now. And this stage is entirely yours. So over to you, Orhan.
Ashok, the reason I posed, because I felt so emotional. So I have never come across so sincere people in my life. Truly, I am expressing this when I visited your country, and the encounter made a huge impact on my not only teaching attributes and teaching style, but also in terms of my interactions with other people. You were like oceans coming towards me with your heart wide open. And thank you very much for inviting me. And this reinforced further my feelings about your country, your people. And as I said to Adi, that is my second country now. I can express here with my sincerity. Now I'm going to go on to the talk, but I don't have the control here, so I would be truly relying on you guys. In the next 20 minutes, I will try to, this is not about giving a talk. I don't give talks. I pass my burden, the weight on my shoulders given to me by my predecessors, my teachers, to the next generations. So that is the difference. If I can achieve that, I would be happy. I'm not going to hide anything, and I'm going to pass you things that I developed over the years. So I hope everybody will enjoy this, and I will make it very simple. So I'm terribly sorry if I made it very simple, but I truly believe that simplicity matters. Simplicity shows that, one, you know the thing, and second, you're willing to teach the core subject. So let's the show begin, shall we? Thank you very much for the lovely introduction. Adi, I think I'm in your hands now. So if you run the slide.
I can open the presentation, Prof, but try and open it from here only. Then you'll have a control. If it is too much, then I'll open my presentation.
So I'm going to open just one thing first as a starter.
Yeah.
Let me just share the screen first. Share screen, and this is just as little introduction. So what we're trying to do here, we would like to instill people to look and see, but also process it, and like this gentleman is doing. So you know this gentleman, all of you, is looking and seeing. So we will all enjoy this. Let me just move on to the main presentation. And have fun together. This talk was given to me about AV septal defect and ventricular septal defect. I modified it a little bit. I hope you don't mind, with your permission. If I show you the presentation, the reason I modified it, I hope it will meet your approval. And if you don't approve it, then I will carry on. Now, for the Indian people, it would be insult to say mango and the melon are the same. But AVSD and FVSD are completely different spectrum of diseases. So therefore, if I want to teach, and the title was also detailed evaluation, it is impossible to give that talk and pass my experience. I can give the talk, but I can't pass my experience and I can't flow to you if I also involve VSD. Therefore, I will concentrate on mango, which is AVSD. And what I would like to say to you guys, when you see or when you hear Down syndrome, when you see AV septal defect, and the first thing you think, wow, learning difficulty, lifelong care. But do you ever think it's not moving?
If you click on the presentation, it will move. There we are.
Do you ever think that there is a person behind it with an affectionate and infectious smile? So I would ask everybody, when you make a diagnosis, always think there is a human being behind it. Also, we need to realize it's not always possible to pick up this abnormality. In the most developed centers and the most developed nations, with established screening programs, pickup rate of AV septal defect between 30 and 75%. It is same in Britain. I think the concentration should be on the basis of how not to miss this rather than how to pick this up. It depends on the subject material, whether the baby is lying favorably, or the pregnant lady has good echo window, or your equipment is well programmed. These two images are from a fetus which was overlooked. Now, I would like to ask audience to send their responses whether they would have called this AV septal defect or not. Answer is yes or no. If you send it to the moderator, we can collect that information. And I'll show you another example. Now, the image quality not as good as the first two images, but this case was overlooked, not only by the sonographer and fetal medicine specialist, but also by fetal cardiologist. Hindsight, it is easy to be clever. And when you're not doing the scan and you have plenty of time, relaxed, and you're not in the middle of your long clinic, each patient is allocated 5 or 10 minutes. And this patient, again, was overlooked. But now we can easily say, this is AV septal defect. But because the image quality is so good, and it's a barn door AV septal defect, it would be a crime to miss this. However, there is a spectrum, remember, and we will never criticize our colleagues and friends and each other. We will be supportive. We need to look for the mitigating factors and other issues. AV septal defect presents itself in 3 forms: partial, transitional, and complete. To understand that, we need to concentrate on the normal anatomy first. And that will be our first objective. And then we will go into clinical types, and I'll try to explain those to you one by one. And I will also give you templates, diagnostic projections. My teaching is based on templates and putting those schablons or templates into your mind, into your subcortex first, and leave it to you to imprint it in your cortex permanently and subcortex permanently to turn it into automatic transition. And we will also give you some diagnostic clues in 10 commandments. Our area of interest is quite large, my friends. It's atrial septum, inlet valves of the left and right, Atrioventricular septum, the green bit, the area squashed between mitral and tricuspid valve, and also ventricular septum, as well as the papillary muscle. Now, this is a summary of what I'm going to say to you. You may leave the talk. You can just click, get this 10 commandments, but I will explain these. They mean nothing on their own if you don't go into the detail and try to identify the features of them. Common AV valve is the one you'll be searching for. We will be looking at loss of normal offsetting of AV valves, abnormal configuration of left and right inlet valves, and then we will count the number of leaflets on the left and right sided inlet valve. We will no longer call them mitral or tricuspid valve once it is identified as AV septal defect, because they don't have the feature of mitral and tricuspid valve. Left-sided inlet valve will have trifoliate appearance. It will have 3 portions, but normal mitral leaflet will have 2 portions, anterior and posterior. We will also make some measurements of the atrial and ventricle length. That ratio should be less than 0.6. So ventricle should be longer than the atrial length, but in AV septal defect, that's different. We will also measure left ventricle to apex to the aortic valve and left ventricle apex to the left inlet valve ratio. That will also give you a clue to the diagnosis. The aorta itself becomes unwedged and displaced anteriorly and superiorly. It lifts up and gives an impression of swan neck deformity. Papillary muscles also affected in this abnormality. They move, one of them move from posterior medial aspect towards anterolateral aspect. And leaky regurgitant inlet valves. Inlet valves become very lumpy, dysplastic, and they don't co-opt well. Pericardial effusion is not the most obvious feature, but it's a feature of chromosome abnormalities which might help you. So those 10 things need to be looked for automatically one by one in a tick box. Now let's move on to the normal anatomy of the AV junction, particularly the atrioventricular septum, which is the areas sandwiched between the mitral valve hinge point and tricuspid valve hinge point. This section provides direct communication between the left ventricle and the right atrium, left ventricle and right atrium, which forms the offsetting of stepwise attachment of the mitral and tricuspid valve. What happens to this junction in AV septal defect? It is lost, and that results of loss of AV valve setting, and the AV valves become linearly attached. They are attached at the same point. Let's have a look at this on an anatomical specimen. In a normal heart, we see secundum septum and sinus septum at the top. Secundum septum is infolding of the right atrium, infolding. It's not a true septum. And we have lower portion of it, secundum septum facing the right atrium and primum septum. And in between, you see the gap. And the gap is the foramen ovale. And then what we see, lower attachment hinge point of the tricuspid valve, higher attachment of the mitral valve, and so-called atrioventricular septum. You can see direct connection from left ventricle to the right atrium. But in the complete AV septal defect, what we see, common AV valve, instead of two separate AV valves, like a pair of glasses separated by your nose. This is the nose or the AV septum, and two separate AV valves. But in complete AV septal defect, there is a common valve, and common valve is caused by a defect at the lower end of the septum called primum atrial septal defect, and also inlet VSD at the top end of the ventricular septum. And loss of AV valve offsetting is the hallmark of this abnormality. Let's look at in entire heart, how it looks like in a normal heart and in AV septal defect. You can see the linear attachment and AV valves being at the same level, versus AV valves in a normal heart has stepwise hinge point. And the distance between the two, we call this atrioventricular septum. And that's the first feature of AV septal defect. And the second feature, when you look at this, common AV valve orifice as opposed to two separate AV valve orifice. We have mitral and tricuspid valves completely separated, but in common AV valve, we have a hole at the top, hole at the bottom, and the inlet valves molded into one inlet valve. We call it common inlet valve. Anatomically and clinically, it may present itself in four different forms, or three different forms, but the first form, partial AVSD, can present itself in two ways. One, partial AVSD either can have only atrial shunt, prime ASD, you may not have any ventricular septal defect, and the two inlet valves are held together by a tongue of tissue. So there is a tongue of tissue holding them together. So there are two separate AV valves. This is the spectrum of AV septal defect. We call this partial. But in the complete AV septal defect, there is no tongue of tissue. They are completely combined into one inlet valve. The second form of partial AV septal defect is the ventricular septal defect in the inlet portion. So there is only shunt in the ventricular septum. Transitional form is in between. So you have two separate AV valves, but shunt at two different levels, atrial and ventricle, but smaller. Usually a large atrial component, small ventricular component. In the complete form, as you can see, large atrial and large ventricular components, and common, most important, the common single inlet. The frequency of these abnormalities are as seen here. Complete form forms the overwhelming majority of 80%. The partial ones between 12 and 25%. Now let's start with the partial one. So defect in this running video, as you can see in the lower end of the atrial septum, or just above the AV valves, which are attaching at the same point, linearly attaching to the septum. And in the cartoon, you can see this lower portion of the atrial septum is missing. So we call this prime ASD. It's commonly associated with trisomies, Ellis-Van Creveld syndrome, Holt-Oram, Noonan syndrome, Mowat-Wilson syndrome, and DeGeorge syndrome. So not only complete AV septal defect, but also prime ASD is commonly associated with genetic abnormalities. One more to familiarize our eyes, prime ASD. And other thing I'd like you to spot, leaky valves. So in not only complete AV septal defect, but also in partial AV septal defect in prime ASD, you have leaky inlet valves. Leaky inlet valves on the right. You can see a flush of color on the right, but more so on the left, you can see here. This is another type of partial AVSD, this time shunt in the ventricular level, at the ventricular level. You can see the lower portion of the atrial septum is intact, but the AV valves are at the same level, linearly attached. In a running video, time to time, you may actually see it as if it is normal. See, attachment may appear normal. You may not appreciate the VSD because the shunt will be immediately underneath the AV valves, and you need to tilt anteriorly to be able to demonstrate it. You may easily miss prime VSD or inlet VSD if you did not angulate properly. You need to angulate. You also need to zoom it. In the first few slides, I showed you missed image. That was the technique that colleagues were taking. They were not zooming the images. They were not stopping the image and looking at image slowly. So what you're going to do, you're going to stop and scroll back and zoom it. Be kind to your eyes. Let's move to the next slide. I think we moved very rapidly. So in this image, you also see VSD and small atrial component. But what you see here, single AV valve, single inlet. That make it easier to diagnose. Complete AVSD and the normal heart shows fundamental differences. Look at the right-sided inlet valve has three sections, septal, anterior, posterior. Mitral valve has two leaflets, anterior and posterior. So bifoliate, trifoliate. But in the complete AV septal defect, we have superior bridging leaflet shared by right and left inlet valves. Sorry, posterior or posterior bridging leaflet or inferior bridging leaflet. We have anterior bridging leaflet or superior bridging leaflet shared by right and left again. And then we have right mural, right anterior, and left mural leaflets. So left one has trifoliate, and right one has quadrifoliate appearance. Let's see it on the cartoon. So they're not two separate, but common valve. Superior bridging leaflet, inferior bridging leaflet shared by right and left ventricles. Mural, left-sided mural leaflet, right-sided mural leaflet, and right anterior leaflet. In an anatomical specimen, this is extremely important. It's a hard cut from the middle. This is the posterior section and opened up like mango. Okay, this is the posterior mango, this is anterior mango. So when you look at the posterior section, you don't see any VSD. You see the prime VSD, but no VSD, because this is inferior bridging leaflet attaching to the septum. So it's obscuring the VSD. You need to angulate anteriorly to be able to see the large VSD under the superior or anterior bridging leaflet. So what you're learning here, you need to angulate. If you cannot see the VSD from posterior bridging to anterior bridging leaflet. The AV septal defect can also show itself either balanced or unbalanced. Balanced means the right and left pumping chambers, ventricles, may be pretty much the same size, and left and right inlet sections may have similar diameters. But in the unbalanced section, which is seen luckily less often, 3 to 5%, it will imitate hypoplastic left or hypoplastic right ventricle if the right ventricle becomes unbalanced. Now, this is very important. I summarized my experience, my knowledge in this slide to you, like I listed all the tips. These are the views and planes that you will obtain in the spectrum, from partial to the complete AV septal defect. In partial one, it's easy. Concentrate on the four-chamber, angulate anterior posterior. Most of the time, you will make the diagnosis. But when it comes to complete, you need to obtain additional views. Subcostal unfast view, subcostal unfast, short axis view of ventricles, or parasternal long axis view to do measurements, to measure the mitral, aortic valve to apex distance versus left inlet valve to apex distance, to see that the aortic apex distance is elongated. Also, you need to obtain short axis view of the ventricle concentrated at the 9 o'clock to 7 o'clock position to show the inlet VSD. This section is specific for inlet. This section is specific for muscular VSDs, muscular. And this is sagittal short axis view to show inferior and superior bridging leaflets and their insertion points. Are they inserting to the free wall, or are they inserting to the septum like inferior bridging leaflet? This is an example of subcostal and fast view on a baby after birth to familiarize your eyes and to make it crystal clear in your eyes. And I will show this picture to you in a fetus too. So you need to stop and roll back. Superior bridging leaflet, beautiful. Inferior bridging leaflet, and this is the mural leaflet. This is the mural leaflet. Let's run it. As it is running, they close in the middle, you can see, and it gives you hash or H shape. H shape, yeah? H shape appearance when they shut. Let's move to the next one and demonstrate it in another baby. This is postnatal. This time elongated aorta. Aorta moved upwards and anteriorly. And you can see the superior and inferior bridging leaflets. This is a normal heart anatomic and cartoon that I drew for you. Two separate AV valves, two sections of the mitral valve. This is the cartoon that I drew. This is three section of the septal, posterior, anterior leaflets, and how it is seen. But when it comes to complete and partial AV septal defect, we have superior bridging leaflet with a gap, anterior bridging, inferior or posterior bridging leaflet, and we have mural leaflet. We have right anterior superior leaflet and left mural leaflet. But in partial one, superior and inferior bridging leaflets are connected with a tongue of tissue. Somehow, right and left inlets are separated from each other, as opposed to common orifice. This is partial AVHD, bigger, larger, from better understanding point of view. And this is complete AV septal defect for you to understand. We have still 1, 2, 3, 4, 5 leaflets, but superior bridging leaflet shared by left and right side. So is the inferior bridging leaflet. Therefore, it makes right inlet valve 1, 2, 3 quadrifoliate, and left inlet valve 1, 2, 3 trifoliate. Now, the abnormality is not confined to the valves only. It also extends to the papillary muscle. In a normal heart, papillary muscle are identified as posterior-medial, posterior and close to the septum, anterior close to the free wall, anterolateral. But in AV septal defect, the posterior-medial papillary muscle moved sideways to the lateral aspect. So they both become in the same quadrant, the right-sided hand of the partition. So superior and anterolateral papillary muscle, superior papillary muscle, inferior papillary muscle, they all aligned at the lateral aspect. Excuse me. Then you need to do a little bit mathematics, a little bit measurement. Now the length of the atrium in four-chamber and length of the ventricle, when they are compared, the ventricle length is very, very long. But in AV septal defect, atrial length becomes longer as a result of this mitral valve moving down, moving down. When you measure it, it becomes more than 0.6, that ratio. Let's measure it. When we measure it in normal heart, when we measure it in abnormal heart, it becomes almost equal. Yeah. So atrial length to ventricle length becomes longer. And this feature on a running image can be demonstrated. Why is it important? Because 82% true positive rate, with false positive rate of only 5.7%. So that's one thing you'll be doing in your practice. Second thing to measure, of course, you can eyeball it. Eyeballing clearly demonstrates it. Then we will move on to another measurement of outflow tract valve to the apex, to the inflow valve to the apex. In normal heart, they are equal. But in AV septal defect, the outflow tract becomes 20-25% longer as a result of mitral valve displacing down. And this gives an impression of swan neck deformity. And due to elongation of the LV outflow tract and anterior displacement of the LV outflow tract. In a moving image and still image, that's how we measure it. From the lateral aspect of inlet valve to the apex, from the septal aspect of the aortic valve to the apex. In a moving image, you can see this straight away raises the suspicion of AV septal defect. Now we come to another tip. The other tip is because of dysplastic, mucoid, lumpy inlet valves and abnormal coaptation, you get leaky valves. You must utilize your color flow. And you can see this one has quite significant leakage. But in the black and white, you would not be able to appreciate this. You can use different color modalities, this one, or you can use this modality, standard color flow. So leaky valves are seen almost 90%, 95% of patients with complete AV septal defect. Now, this is the image that I developed over the years. We use this quite commonly in babies and children. We call this unfast view of AV septal inlet valves. So we're looking at the inlet valves from the top, from the atrial aspect. How do we do that? We either do it from subcostal view or from the sagittal view. So this is a normal appearance of a fetus. You can see two separate AV valves like a pair of glasses separated from each other by the ventricle. And this is the cartoon. Let's have a look at the abnormality. Oh, it moved quickly. There you go. So this is normal, and this is the abnormal in the fetus. You can see common AV valve, inferior and superior bridging leaflets, inferior and superior bridging leaflets. We use this section to demonstrate VSD. If you look at this, VSD is here. This is not VSD. This is the atrial communication between superior and inferior bridging leaflets. Watch this carefully. See, this is not VSD. This is the atrial communication. This is superior bridging, inferior bridging leaflet. This is superior bridging leaflet. So VSD is here, here. Now you can see beautifully when I stop this, now the VSD is beautifully visible there. Yeah. And VSD will be visible in this plane, if it plays. There. So this is the VSD. All right. So this view is easy to obtain. Don't worry. It is not cardiologist view. And I am amazed, absolutely astounded by the skills of Adi and Adi's colleagues and Dr. Kumar's skills and other faculty skills to do so sophisticated image acquisitions and sophisticated analysis with your state-of-art machines. The machine you use, we still don't have it here. So this is a cartoon. I am going to put still image and I'm going to put cartoon on it to make it easy for you to understand. So you can see this is the septum, this is inferior bridging leaflet, this is superior bridging leaflet attaching to the either end of the free wall. And you can get this from sagittal view, and you can also see the aorta, elongated aorta. And you can also see by putting color if there is any leaky valve. This is not the best view to demonstrate leaky valves. 4-chamber view would be ideal. Now, when it comes to short axis view, standard short axis view would fail you to demonstrate inlet valve. But if you obtain ductal arch view, then you would see beautiful inlet VSD. So ductal arch view would demonstrate you inlet valve, not the standard short axis view. Standard short axis view will show you perimembranous VSD, not inlet VSD. Now I came to the end of the show. I'd like to offer you 3 take-home messages out of that 10 tips. Loss of AV valve offsetting, resulting in linear attachment of AV valves on 4-chamber view. Downward displacement of mitral valve, resulting in elongated LV outflow tract view, and on unfast view, common AV valve. Common AV valve orifice causing leaky left and right-sided inlet valves should be looked for. These are the 3 messages that I would like you to take home, but you can always take anything you like, measurement, and retain at least one of them forever. Retain 3 for 1 year or forever with practice, and I'd like to say thank you to you for your patience. If I have time, another 5 minutes, I would go on to clinic and the epidemiology treatment, if I'm allowed to do so by the moderator. Thank you very much.
Most certainly. Thank you, Orhan, for that. And please do take the extra 5 minutes for what more you wish to tell us.
Okay,
Yes,
let's move on. So
yeah.
if I share screen again.
Yes.
Now, I'd like to mention to you associated abnormalities. Now, of course, AV septal defect doesn't come on its own. As I mentioned to you, it may be an unbalanced AV septal defect. This one is mimicking hypoplastic left heart syndrome. So you need to look for the size of ventricles, also size of inlet valves. So what you're going to measure? Size of inlet valves, because it is important in terms of prognostication and counseling. Single atrium and single AV valve. And this is more difficult to deal, and it is not amenable to septation sometimes, and you may not be able to repair this, but you may need to go through palliative route. 10% of AV septal defect is associated with overriding aorta and pulmonary stenosis. So you need to exclude pulmonary stenosis by looking at short axis view. But what sort of short axis view? Ductal arch view. And this shows anterior deviation of the septum, inlet VSD, and turbulent flow across the pulmonary valve. So tetralogy of Fowler. This is single atrium and balanced AVSD, but also what you see here, eyeball assessment, when you look at here, heart is moving slowly. So there is bradycardia. Why there is bradycardia? Because the appendages here, Master Adi can tell you in isomerism lecture, which is outstanding, broad-based appendages is telling us this patient has right atrial isomerism. Therefore, this patient is likely to develop heart block. So it's not just AV septal defect, but also isomeric heart. Abnormal ductus venosus flow is quite common in AV septal defect patients because of abnormal loading. Coarctation, although it is rare, can be seen between 3 to 10% of AV septal defect patients. Either coarctation, what we see here, we see the ductus attaching to the descending aorta, but ascending aorta becoming very small, very thin, and coarctation. This may go on to extreme form, where there may not be any communication between ascending aorta and the descending aorta, interruption. So this is seen, as I said, between 2.5 to 10% of individuals with AV septal defect. It is seen between 4 to 10,000 live births. In Wales, we have between 10 and 12 cases. Some years 5, some years 12 cases. And we see 7% of stillbirths will have AV septal defect. 14% of women with common AV septal defect will pass some sort of congenital heart disease to their children, not necessarily AV septal defect. Remember, 11% of fetuses with AV septal defect will have at least one proband, one family member affected by any type of congenital heart defect. Genetic associations is vast, between 50 and 75%, from trisomies to Noonan, from Noonan to 20q11, and heterotaxy will be seen between 10 and 40%. 10% in simple AVSD, 40% in complex cases. Okay. What is important? Non-syndromic AV canal defect, which is 50% of AV septal defect, appear to be more associated with maternal diabetes and obesity. So what we say, about 50% of AV septal defect patients will have Down syndrome. Equally, 30 to 40% of Down syndrome patients will have AVSD. Remember that. And there is a list of abnormalities can occur in AVSD in complex forms, from coarctation to TAPVD. And it differs whether baby has syndromic or non-syndromic. Abnormalities in syndromic and non-syndromic ones may vary according to presence of syndrome. In non-syndromic patients, isomerism more often. In syndromic patients, musculoskeletal abnormalities, eye and ear abnormalities. So that might point you towards Down syndrome or syndromes. Renal abnormalities more often non-syndromic ones. Central nervous system abnormalities more common in syndromic ones. What do we do with these patients when they are born? Until pulmonary vascular resistance drops, these patients may miss medical attention. But once PVR drops and the flow into the lungs increases, these patients suffer from breathlessness, intercostal recession, faltering growth, and they don't feed well because of edema in their gut and breathlessness. And 2 weeks after birth, we put them on diuretics or anti-failure treatment or nasogastric feeding. Once they reach 4 to 6 kilograms, we do refer them for surgery, certainly before 6 months of age, because of danger of pulmonary hypertension developing. Surgery may involve either single patch or 2 patch repair. You either put 1 patch and pull the septum up, or you use 2 separate patch, 1 for the septum in the atria, 1 for the septum in the ventricle. So I'm going to move quickly. And the outcome, 10-year survival, historically between 80 and 90%, depending on the centers, and 30-year survival, 70%. Contemporary outcomes, 96% survival rates first year. Reoperation rate, 10% in childhood, 25% in lifelong, either repair or AV valve replacement. About 3% risk of pacemaker implantation. This is UK data. If it is partial AVSD, 30-day survival between 90 and 100%, 1-year survival 95%. If it is complete, over 90% survival, 95% survival, 30-day survival, over 90%, around 90% survival. It varies year to year from 84% in 2004, it moved to 90% recent years. AVSD tetralogy of Fallot, surprisingly better outcomes. So adding 1 abnormality does not affect survival. 100% survival recently, 30-day, and over 90% survival like complete AV septal defect after 1 year. Well, thank you very much. Without clinical information and survival data, I think it would not have been complete. I finished my talk, but I might have exceeded my time. Apologies.
Thank you. Thank you, Professor, for one of the most delicious pieces of education that we have received during this pandemic. This absolutely phenomenal combination of your pace of teaching, your cartoons, those absolutely wonderful templates, and the real life demonstration was amazing. I don't think we've really had this treat for a long time. We've seen a lot of technology, but we've seen very few people who teach so beautifully from the heart. Thank you indeed. Our audience has been so completely engaged that we only have 2 questions for you. And if I may take a couple of minutes and then we move on to the panel discussion. The 2 questions are, the first is a very innocent question, and is, do we measure the left ventricle in diastole or systole?
Remember, left ventricle in diastole is biggest, and atrium, systole, and the biggest. So what you need to measure to avoid mistakes, you need to measure in diastole when the left ventricle is biggest. In diastole, left ventricle dimension will be bigger. So if you measure in systole, then the left atrium, atrium will be bigger, and you'll be biased towards wrong measurement. So if you do measure in normal hearts, right atrium will measure bigger than the normal left ventricle diameter anyway. So you can't take this systolic dimension. In systole, right atrium is always bigger. So it will give you false measurement, false impression that it is AV septal defect. Hence, you should measure it in diastole, when ventricle in diastole, when it is the biggest dimension.
Thank you. And the second question is, can we have a loss of offset without the associated septal defects, which means no defect of the atrial septum, no defect of the ventricular septum, and my valves are all on a straight line?
Excellent question. Yes, I'd like to ask audience, yes, there is such entity and what it is called. If you answer correctly, I will send you a prezi. Whoever knows this question, and if there are many people, then we will ask Prof. Khurana to choose one or two or three, a maximum three, and I will send you some lovely prezi from here to India to your address. So there is a condition. So the reason I'm talking, to give you 15 seconds thinking. Now, when I say that's it, you missed your chances, then we will discard the answers. It's called form first AV septal defect. Form first, F-R-U-S-T-E. And this is well-known sign of Down syndrome, trisomy 21. And I had, over the past 20 years, 6 of these fetuses. In fact, Prof. Anderson and colleagues from Brompton, they did a study, anatomic and clinical study, and published their paper. I can send it to you. I was going to write it in fetus, but I couldn't come to it. I don't think there has been any fetal paper on that, but I had 6 cases and I can demonstrate it. Yes, it is possible without ASD and without VSD. We call it form first. So I'm curious how many people answered that.
Nobody answered that. The question was also honestly not from the audience. The question was from here.
Oh,
You know, you've truly held our audience so engaged. We have no questions so far, but I'm going to keep an eye on the chat box and ask you the question at the end of the session. And thank you so much for this absolutely marvelous presentation. And I know you're going to stay on with us for our panel discussion as well.
I'd like to learn from you. I'm honored, truly honored. I'm blessed, honored, and humbled. Thank you very much.
Thank you indeed. And before we move on to our panel discussion, if we can run our trade partner videos again, I'd request our back office to give us our messages again, and then on to the panel discussion.
The unique role that pathology plays in the science of healing is now at the tipping point, reshaping the future of pathology itself using 21st century tools and technology combined with big data analytics. These changes will help pathologists diagnose diseases with greater speed and precision than ever before, arming them with technology-based insights that will help identify diseases faster, more accurately, and at a lower cost. Ushering in a new era where genomics, syndromic panels, and liquid chromatography reduce recovery time and exponentially increase the success rate of recovery. A future where the world is connected and distances are shrunk to deliver better diagnostic results. Welcome to that future. A future that is inspired by geography and united by technology. Welcome to Newburgh, a whole new world.
And with that, over to the panel discussion.
Thank you, sir. This was an excellent presentation for Dr. Orhan. I think fabulous. And you made things so simple. And I think that speaks volume about the presenter. Let me now try to share my slides first and then, all right. So are we done? We visible and audible? All
yes,
right.
visible and
All
audible.
right. So now we have our masters with us who would be giving a final verdict, and he would ask questions of his own also, like he did last time. But I absolutely agree with Dr. Orhan that if you can't explain it simply, that means you actually haven't understood it well. And people, those who've understood things so well, only those can explain things in such a simple format that it looks so easy, looks cakewalk. Let's try to do the same here. And I'm involving Dr. Orhan again in this panel discussion. And I would be asking him questions regarding echocardiography techniques in various conotruncal abnormalities as I present the cases. Dr. Adyanarayan Makam, I would be requesting him. He is a director of Adi Advanced Center, and he was trained in Cardiff, UK with Sir only. And I would be asking him extra cardiac abnormalities and, you know, what is the differential diagnosis in a particular case. Dr. Divya Singh is an MD radiodiagnosis. She is a fellow from Mediscan. She's working with us, and she would be giving a radiologist perspective that, you know, what are the fallacies, you know, where do we actually misunderstand things and how do we improve? Dr. Munesh Tomar is a pediatric cardiologist in Delhi. She was in Medanta. She's moved now. And we would be asking her that even in this COVID time, should I get the delivery done at a tertiary care hospital, or can we manage it at a primary centers rather than for all cardiac and the cases which I present? Dr. Rohit Manoj is a professor and in charge of Unit 2 in one of the prestigious institutes in Chandigarh, that is PGI. And he is a pediatric cardiologist, and we would request him to share that what are the parameters, you know, in the neonatal echo. And I would still like to ask him in various cases that what did we miss and what we cannot pick up on fetal echo, which, you know, he would be able to do it in a neonatal echo. And what do I counsel my patients about surgery and interventions, and what do I tell them the long-term prognosis? Dr. Minakshi is a DM genetics from SGPGI Lucknow. She was in Gangaram initially, and she is also working with us full-time as a clinical geneticist. And she would, you know, tell us all the complex things about genetics, the algebra, and not only counseling the parents, the referring doctors as well. So we have a big brother with us. His verdict would be final, and he would kind of sum up the entire situation. Just to brief, what is conotruncal abnormality? Conus is a kind of an infundibulum. You do have two coni when you begin in embryology, but not going into detail. Conus is infundibulum, and truncus is a proximal portion of both arteries. I mean, that's too simplified way of explaining, but anyway, that's better. Truncus, and so that this, all the abnormalities here share certain common features. And, they develop from a common place, that is neural crest, second heart field, and then there is a septation. If there is an abnormality of septation, you would have a truncus arteriosus or a common arterial trunk. And in case there are other abnormalities of conus, then you would have various forms like tetralogy of fellows, DORV, and TGA. So they share a common thing. They constitute about 10 to 12% of all congenital heart disease. Varies between the center and expertise and tertiary, primary. The most important thing which I want here to share, that they tend to have a normal 4-chamber view. I mean, that's something which is very, very important. If you are still stuck with old guidelines of ISOG and you're just doing 4-chamber view for screening of the heart, you probably would miss all the conotruncal abnormalities. So diagnostic accuracy for the same reason is little lower. Termination of pregnancy is higher because they are very commonly associated with extra cardiac abnormalities, genetic disorders, and survival rate also is not too good. And they have a significant, if I pick up a disease in prenatal diagnosis, it would have a great impact on the outcome. Not like just a VSD. I mean, it would not make a difference whether I pick up prenatally or postnatally. Their prenatal diagnosis is going to be very, very helpful. So that's large data from South Cochin, Dr. Balu, who is about 2 years data. And this is the spectrum of conotruncal abnormalities in 68 patients they have. We also share the similar kind of data. Tetralogy of fellow is the commonest, and very close is DORV in about 300 cases, what we did in last 5-year period. So now I begin with the first case, a 22 years old female who has who's a primary gravida, and rest everything is fine. She just comes at a gestational week of 19 weeks plus, and referred was abnormal cardiac morphology. That in fact is the commonest referral for a fetal echo, and rest everything was unremarkable. And that's what we get on a fetal echo. We have a left ventricle, a right ventricle, and we get a large ventricular septum defect, which is a perimembranous or a subaortic to call. And there is an aortic override, about 50%. And this is the cartoon overlay, which can demonstrate what I am trying to say. Apart from that, the override, the pulmonary artery is smaller than aorta in modified 3VT. And that gets us to the diagnosis. That is a tetralogy of fellow. So now I invite Dr. Orhan to please, elaborate various points and markers of assessment of tetralogy of fellow.
Thank you very much. In tetralogy of fellow, you will need to consider two most important anatomical problems, which are VSD and pulmonary stenosis. Remember, those are the ones determine the clinical scenario, and also they affect surgical intervention and outcome. The rest are consequence of these two abnormalities. And if the pulmonary stenosis is severe, it could involve either the most commonly below the pulmonary valve, which is called infundibulous stenosis. But half of these patients, tetralogy or fallow patients, will also have additional stenosis either at the valve level or in the branch pulmonary arteries. So infundibulous stenosis is seen 95% of the tetralogy cases. Very rarely it could be a valvar pulmonary stenosis in tetralogy, but 50% of patients with infundibulous stenosis will also have additional narrowing. So you must look for the site of narrowing. And the second thing is VSD. How big is the VSD? And whether VSD is affecting the orientation of the aorta to the right or to the left. What I mean by that, if the orientation is anterior deviation, then it causes pulmonary stenosis. If it is posterior deviation, then after you close the VSD, it causes subaortic obstruction. So that's what it is important.
Professor, you got muted.
I'm talking.
No, you got muted again. Just for the last minute, but you got muted again. Now you're back again. Yes. Yes.
How far did I come? Did I explain the narrowings?
Yeah, everything.
Yes, you were talking about the displacement between displacement of the aorta. Yes.
Yes. If the tip of the septum displaced anteriorly, then it is favorable in terms of repair of the VSD. If it is deviated towards the posteriorly towards the left side, then after closure of VSD, these babies tend to get, or patients, aortic stenosis, which is not good. Other thing I'd like to mention to you, overriding aorta is misleading if it is measured from long axis view. It must be measured from 5-chamber view. So you must always remember the most accurate assessment of overriding can be done from 5-chamber, not from long axis view. The VSD itself is single most of the time, but about quarter of patients will have also additional VSDs. You need to remember. If VSD allowing aorta to move to the right more than 50%, it will go on to a different spectrum called double outlet right ventricle. In those cases, you need to look at mitral to aortic valve discontinuity. So if there is no mitral to aortic discontinuity, then it is unlikely to be double outlet right ventricle. You need to go back and remeasure override. In tetralogy patients, right aortic arch is also quite common. So 3-vessel trachea view would come very, very handy to look at these patients, whether their arch is right-sided or left-sided, because of association with 20q11 deletion. In tetralogy, the risk is about 10%, but if there is right aortic arch, risk goes up to 15–20%. Is that enough? Or do you want me to elaborate more?
Yeah, I think maybe you can make a mention about absent pulmonary valve, because that again.
Yes, I will mention about
spectrum.
that.
Yeah.
So spectrum of tetralogy fallow, there are 4 different clinical spectrum. In fact, 5. As cardiologists, we look at 5 different spectrum. 1, bona fide tetralogy of fallow with no other associations. 2nd, double outlet right ventricle tetralogy type. And the 3rd, tetralogy of fallow with absent pulmonary valve syndrome. And the 4th, you have pulmonary atresia tetralogy type. And you get 5th, tetralogy of fallow with AV septal defect. So the 5 forms should be actively searched. And in those babies, depending on the degree of shunting into pulmonary artery or systemic circulation, those babies have either cyanosis if pulmonary stenosis dominates, or if they, not pulmonary stenosis, but if the VSD dominates, and they do develop more heart failure symptoms, and they become pinker. We call them pink tetralogy of Fallot. In absent pulmonary valve syndrome, in fact, pulmonary valve is present, but it is dysplastic, severely stenosed, immobile. Therefore, in these patients, I think differentiation is going to be easy for you, because you will see significantly abnormal forward flow, turbulence, and increased velocity, and fro, what we call it to and fro murmur, or to and fro flow. And it will come back straight away. What goes out will come back. So when you put the Doppler, you will see Doppler pattern up and down following each other, or color flow pattern following each other. The other special feature of absent pulmonary valve syndrome, you will see significantly dilated main pulmonary artery and branches. The branch pulmonary arteries will look as big as the aorta, and they will impinge on the trachea and branches. Right and left bronchus might be somehow constricted or compressed by these branch pulmonary arteries, massively dilated pulmonary arteries, either antenatally or postnatally. And the other thing to look at, absent pulmonary valve, more associated with 20q11 deletion. And the other thing is important with absent pulmonary valve syndrome. These babies tend to have either duct or no duct. And if there is a ductus, then the branch pulmonary arteries are not so big. And if there is no ductus, then branch pulmonary arteries will be very, very big. And that's what I would like to say about absent pulmonary valve syndrome.
Yeah, thank you, sir. Thank you. Great. I think next question comes to our mind, that what are other cardiac and what are other extra cardiac abnormalities? And as a sonologist, what are our challenges in making a diagnosis of tetralogy? Dr. Adya Narayan, would you elaborate on extra cardiac abnormalities and the differential diagnosis for a TOF?
Sure, sir. First of all, thank you very much, sir, for wonderful slides. And you've given us the slides before in hand, very helpful. And Ladbant ma'am for organizing and getting all of us together. And Ashok sir for giving us a wonderful platform for all these academic activities. And Prof, I don't know, I can listen to you any day, any length of time, and you speak from your heart, and it directly grows to the cortex. And I'm very blessed that I train under you, and I wish and I feel that I should pass on what all you taught me to all my junior colleagues. And I'm really enjoying, and I'm looking forward for you to come to India, at least spend 1 month a year, which you promised. This is your second country, and all of us are here to welcome you and learn from you. Thank you, sir.
Namaste. Namaste.
Namaste. Right. Coming to the question, can I answer the second question first, Dr. V P Singh?
Yeah, whatever.
What the challenges I personally feel with my fetal medicine brain, I'm not a fetal cardiologist, pediatric cardiologist, but in my obstetric brain, when I scan, I come across a lot of normals as overriding. And several times, the normal heart looks like an overriding aorta. Many times, what saves me is the size of the pulmonary artery. Of course, we have a wonderful machine, and I wish one of the GE company should present one nice machine to you, Prof. We are blessed with high-end machines, but several times we find it difficult to identify, we identify normal as overriding. And looking at the pulmonary artery size, many times we conclude that it is normal. And as Prof said, we need to look at the 5-chamber view rather than the long axis view. to diagnose tetralogy fellow. And if it is a very obvious tetralogy, it is very easy to diagnose. But where we find a problem is when it is subtle overriding. And subtle overriding can be extremely difficult at 18 to 20 weeks. And if we get some time, and if we can scan the baby later part of the gestation, this overriding can be a little bit more easier. At 20 weeks, sometimes it's difficult. And at the most, we may diagnose only the malaligned VSD, a small malignant VSD. And again, that also has got a lot of artifacts. So it will be difficult. And in my hands, it is difficult. And we are trying to come up with an answer. I will share that when we meet all together. That is the first second question. And the first question is extracardiac abnormalities. There are several extracardiac abnormalities. To be honest, it is academic, but also it has got some implication when we counsel the patient. And when we actually look at the heart as a good fetal medicine principles, if there is one abnormality, you look for other abnormalities of the same system and other abnormalities of the other systems. So in the cardiac itself, you have several abnormalities. I think there is one more slide, Dr. P Singh.
I think that's what it is.
Okay, that's fine. So this one, today morning I read this paper. This Sarah Piran from Canada. Nice paper. They looked at, they screened the adult population who look like syndromic and who already been proven as 22q11, and they looked at the abnormalities in non-syndromic. And if you look at that, the numbers are similar. That means to say, even when everything looking normal, the extracardiac abnormalities can be common, especially the musculoskeletal, genitourinary, ear, and central nervous system. Central nervous system is neuropsychiatric disorders are quite often seen, even when there are no other abnormalities. So this has a significant impact on our counseling for our patients, and our patients deserve to be told what all problems they can expect after birth. And several abnormalities may not be diagnosed before birth, and some will come up after the birth as well. So this will help us to tell about the prognosis. Thank you.
Adi, I absolutely agree with you. You know, as a fetal medicine specialist and even otherwise in life, you have to have a checklist when you are doing it. Otherwise, there's a very good saying that what is the most commonly missed abnormality? And the answer is the second one. You get so involved with the first abnormality, you tend to forget the second abnormality, or you tend to miss it. We have Dr. Divya, who's a very experienced radiologist. So the question to her is that, you know, as a beginner radiologist or a person who's beginning to do a sonography, you know, what are the challenges they face in making a diagnosis of tetralogy of fellows?
Good evening, everyone. Before I speak about the fallacies and the diagnosis of conotruncal anomalies, I would like to take this opportunity to express my sincere gratitude to Dr. Ashok Khurana sir, Dr. UP Singh sir, and Dr. Ladbans ma'am for giving me an opportunity to be a part of this distinguished forum. And I hope all of you who have joined us here today have a lovely evening. Now, what is a fallacy? Fallacy is a deceptive appearance which misleads the eye, and it can lead to both a false negative and a false positive diagnosis. Professor Orhan has made my task really easy by alluding to the potential pitfalls of fetal cardiac scanning. And there are certain fallacies which can occur while you're screening for any cardiac abnormality. For instance, if your scan settings are not proper, for instance, you have not magnified your image properly, you can miss things. It would be just like if I do not put this PowerPoint presentation on a full screen mode and just keep it minimized on the screen, you wouldn't be able to read the lines on the slide or appreciate the content of the slide. The same way, when we perform a fetal cardiac examination, we need to magnify the heart properly. Relying solely on static images also leads to fallacies. And as Professor Orhan has demonstrated exquisitely, you need to keep looking at dynamic cine loops and save them as you move along, because they can help you in looking back at things in case you've missed something. Third is what I call chromophobia, that is fear of using color while you're screening the fetal heart. Even if you're screening a low-risk patient, it is imperative that you use color Doppler liberally, as it can provide you a wealth of information. Once you set your machine settings right, the next thing is to have a systematic, meticulous protocol which you follow obsessively each and every time, starting from the fetal upper abdomen, moving cranially to the upper chest, making sure that you've looked at all the structures in various planes. Now your machine settings are right, you have a systematic protocol. Still, there can be challenges posed by maternal body habitus, lack of liquor, and unfavorable fetal position. Now, if there is a high BMI patient, you can work with your machine settings and also use color Doppler to your advantage. So color Doppler is your friend. Now, if I come to certain fallacies which are most specific to tetralogy of Fallot, these would include the fact that tetralogy of Fallot is not a single disease entity, but a spectrum. As we already know, it ranges from milder degrees of pink Fallot to severe forms where there is pulmonary atresia. Now, in these milder forms, they can be easily missed because the difference in the vessel caliber, which Dr. Adi alluded to, may be very subtle, and you may not be able to appreciate this subtle difference in the vessel caliber if you look for that alone. Also, the malaligned VST may be missed at times. And to avoid that, it's a good idea to insonate the septum from different angles. By this, what I do is to look at the septum, say when the cardiac apex is at 12 o'clock position, and then look again when it is at around 3 or 9 o'clock position. And to make use of the 5-chamber view, as Dr. Orhan alluded to. Also, the right ventricular tract obstruction that we see in tetralogy of Fallot is something which can be dynamic and may be missed early at the time of the 18-20 week scan. Coming to certain conditions which can lead to a false positive diagnosis of tetralogy of Fallot, as you see in the next slide. Well, this is one such image. Now, when we have these high-end machines, as you see in this image, there can be sometimes a suspicion of discontinuity, as you see here pointed by the arrow. But note that this discontinuity is seen in diastole when the aortic valve cusps are closed, and this is above the level of the aortic valve. So this is not a true discontinuity, because what we know is that the interventricular septum stops below the aortic valve. So this is just a false impression of discontinuity, which can lead you to a false positive diagnosis. Another reason is the overcalling of aortic dextroposition or override, which has been alluded to by the previous speakers. And this can be avoided by using a 5-chamber view rather than using a long axis LVOT view, and by using color Doppler, as in this case, the aortic override would not show any color flow across it, since it's just artifactual. Why this occurs in the LVOT view is because what you've taken is an oblique plane of the chest and not an axial plane. And as a result, you get this false impression of aortic override. With this, I would pass on the baton back to Singh sir.
I think I fully agree with you. Most of the times what happens, the subaortic part or membranous part of the septum is really thin, and you can have a dropout in that area as well, apart from what Dr. Divya showed in the sinus of Valsalva, so the aortic wall defect. But truly in that area where you naturally get subpulmonary VSD, subaortic VSD, that area is thin and you can actually have a dropout there, becomes really difficult. And aorta, as it starts from LV, it originates, it goes to the right initially. So if you have a dropout in the perimembranous area and the aorta goes to the right, and many a times, like Dr. Adi said, it does give an appearance as if there is an override of aorta. So there, the color Doppler comes to your help. You have to minimize the box to smallest possible area, increase the sensitivity of the color by increasing line density, and then record a video clip. And then run this video clip backward, forward at a slow speed in your machine and try to look for an out of phase flow. You know, in case you have a flow outside into the aorta and you're getting the same time you're getting another flow, it may not be a VSD. When you're not getting any other color in the heart and you see a flow across that dropout, that is a VSD. So it's, I mean, still not the, I think it's the commonly missed abnormality, the perimembranous VSD. But there are certain helpful clues by which you can actually differentiate between a VSD and a dropout. And pulmonary artery may not be small always, like in pink tetralogy Dr. Divya has alluded to. So that becomes very difficult. You just have what? You just have a subaortic VSD. And the pulmonary artery size, we did have one case like this, and the pulmonary artery size is normal. So anyway, so let's move forward. And these are the fallacies and we have improved over years for tetralogy of fellow diagnosis. And the problem basically is that we started with 4-chamber view as the guidelines. And LVOT and RVOT views are still difficult for radiologists to, actually get even now. And, after some struggle, I think we try to give up. But that's the lesson. Like Dr. Divya said, you have a checklist. Unless you've seen LVOT, unless you've seen RVOT, please don't proceed further. If you do a 4-chamber, aorta, pulmonary artery, or RVOT and a 3-vessel view, I think you won't miss a significant cardiac abnormality. The slide itself tells you that genetics is complex. So Dr. Meenakshi here, she is a DM genetics, and the DM genetics is, Dr. Khurana, is as complex to me as, arrhythmia to you. It's very complex. Anyway, Dr. Meenakshi would enlighten us probably. Dr. Meenakshi, are you there?
Yes, sir, I'm speaking.
Yeah.
Am I audible?
Yeah, now, yes.
So a very good evening, everyone, to the esteemed panelists and the audience as well. So being a geneticist, first of all, I would like to consider, like, am I dealing with a syndromic kind of a TOF or a non-syndromic? So syndromic per se, to put it simply, means that it is associated with multiple malformations, and non-syndromic, I would say, is the isolated TOF. And this is very important to remember. Then the isolated TOF is commoner as compared to the syndromic TOF. So the syndromic, we always start from the chromosomes. So the chromosomal causes of tetralogy of fallow are around 30%, and they range from trisomy 21 to 18, and even to the small break points and 22q11.2 deletion, which is very common, as we know. And then from the chromosomes, we move on to the single gene disorders. The single gene disorders, they can be like the opids, allergy, Noonan, charge, and even cystic fibrosis. Now that might be a chance association. But these single gene disorders, some of them will have associated malformations like Noonan. It can present with an increased nuchal translucency to you, sometimes with the pleural effusions and the dilated lymphatic sacs, and the increased nuchal fold it persists in. And sometimes these, like the SOTOs, it will not have anything else. The phenotype will present after the baby is born. So then you will have a TOF presenting in a child with a global developmental delay. So here it is very complex. Now coming on to the non-syndromic, the isolated TOFs, these are the majority TOFs, like in the fetus or the child. In the fetus, you see only the TOF is the problem. And in these cases, the chromosomes ones are not so important. The chromosomal is less important, but the single gene takes the precedence. And I more commonly will think of these when I see a familial clustering of the cases. And and if there is a reoccurrence in the siblings, because empirical risk of reoccurrence for TOF, we say, is about 3 to 4%. But if there is a reoccurrence, I tend to think of the single gene entities. And now the FOX2 gene, like it is represented here, And this is actually a syndrome, like the LD syndrome is there, but the child first presents with TOF and later on you have the systemic abnormalities. So you have to consider the phenotype evolves actually from the fetus to when the child is born. So basically it is very important how we counsel the patients and what all testing we do when we see the TOF. So I think that is in the next slide, sir. Next slide. Yes. So my main purpose is like what should be the genetic testing. I'm all for microarray because we know karyotype has taken a backseat now because now we have high-end microarrays. So if there is a TOF and there are multiple extracardiac anomalies, or if there is a TOF with increased NT, definitely microarray should be done. So that is the take-home thing. Microarrays should be done in these cases. The yield is somewhere around 6%. You will get a variant of uncertain significance. The parents should be told that, because when you get a VUS, as we call it, then you have to retrograde, you have to go a step back, and then you have to test the parents. So you should tell this beforehand. I will tell this beforehand to my patients as well as to the doctors. See, you might also require parental testing, right? And if there is isolated TOF, if there is abnormal cardiac angle, I will still go for a microarray. But if there is isolated TOF and there is no extra cardiac anomaly, the cardiac angle is okay, still a microarray can be done. But if there is a typically isolated TOF and there is familial clustering of the cases, or there is a previous sibling, then I would go towards the single gene testing. And the yield here will be very less. This should presently be told, like these very costly and high-end tests are done. It is not that we will get 100% answer in every case. This should be the thing. The yield in these NGS-based panels will only be up to 30%. That should be very well remembered. And sometimes what will happen, that we should tell, if there is isolated TOF, these patients can even have developmental delays later on, because there are some single gene entities, like I told, SOTOs and the others, which will not be able to pick up prenatally. So that counseling part is also very important, that you do all these testings, you get every negative results, still you can never rule out each and everything. So TOF for me, with extra cardiac anomalies, I would go for microarrays, abnormal cardiac angle microarrays, and isolated TOF, no clustering, nothing, we can leave it such.
That's wonderful. That's wonderful. Now we have pediatric cardiologist, Dr. Manish, and we would like to add another angle to our counseling, that, what are the parameters or kind of red flags where I tell the parents that delivery, despite COVID situation, has to be in a super specialty hospital with a tertiary care pediatric center.
Very good evening, sir, and thank you very much for this academic feast in this corona phase. When we see, I will slightly change the question answer into this. When we get a congenital heart disease detected in fetal echo, most of the time the obstetrician asks when to deliver the baby. Can we we can go to the term, or how to do we need to go for cesarean, or we can try a normal delivery, and where it should be done, and what should be the delivery room preparation. Okay, so these all steps has to be discussed with the family and the obstetrician from the pediatric cardiology point of view. And the answer all depend on the how hemodynamically we are going to expect this baby to behave. So if there is no hemodynamic duration we are expecting in immediate at the time of birth, means delivery room, like in tetralogy, pink fellow, truncus, usual truncus, type 1, type 2, where it behave like a VSD only. So they can be delivered like any usual delivery, either by cesarean, depend on the indication of cesarean, not because of congenital cardiac defects. And you don't need any extra preparation in the delivery room, except your pediatrician or neonatologist should be there. So usual norm will be followed in this condition. When we are not expecting any hemodynamic compromise in the delivery room. Second term is when we expect minimal hemodynamic compromise. Okay, so that is the tetralogy of Fallot with severe pulmonary stenosis. So it is narrow, but ductal flow is usual. It is not reverse. Means antegrade flow is there, but PS it can progress, it can misbehave. So we need to be ready. The prostaglandin infusion should be ready, but you need not to start empirically. Plus type of delivery, again, depending on the obstetrician indication, not depending on the congenital heart defect. And another thing is, in whatever the congenital heart disease detected in fetal echo, try to continue it to the 38, 39 weeks of gestation. More the weeks we add, better our outcome will be there. Beyond 42, obviously nothing is going to add. But preterm is going to compromise our additional risk is going to happen in these babies when we go for the preterm. So we need to continue. We try to continue. If there is no fetal distress, we try to get a term baby. Then comes the likely hemodynamic compromise in delivery room. Likely hemodynamic, it is a TGA where your PF foramen ovale is small, means there is no definite ASD. When TGA with VSD, then obviously you go with the normal, means first group. So usual delivery, wherever it is being done, and elective OPD evaluation, surgery, second, third week of the life. Okay. Fourth one comes when you are going to expect a severe hemodynamic compromise. So that is TOF absent pulmonary valve is the one situation, which is a very difficult neonatal issue. Fetal and neonatal both. Fetal absent pulmonary valve, which we have discussed. And the reason is it is TOF. They are not cyanotic because antegrade flow is good. But because of neonatal pH, there is high pressure pulmonary regurgitation leading to cardiac failure. So whatever we do, we usually stuck with these babies. So their nursing is very important. Their ventilation is very different. Everything is very different for the TOF absent pulmonary valve situation. In fact, any valve regurgitation situation, we are stuck with these babies in neonatal ICU. So our TOF different variation, TGA different variation, truncus different variation, truncus with interrupted aortic arch, you have to deliver in the place where there is cardiac facility. TGA with a small ASD, you have to deliver in a center where there is a cardiac facility. Absent pulmonary valve, you have to deliver where there is a cardiac facility. Otherwise, you go as a normal routine pattern, but early elective OPD cardiac evaluation is important in those babies. When you are expecting a hemodynamic compromise, you have to be ready for everything. Better to be on safer side. Keep extra preparation ready than sticking in because obviously there are limitations in the fetal echoes. Interrupted aortic arch is one thing, especially with the truncus, where I will put a question mark. Sometime we can miss.
I think we'll discuss truncus, and for the time being, Dr. Manish has really brought out a very nice aspect, that progression of the disease. You might have okay looking kind of pulmonary stenosis, but that is on 18, 19 weeks, but it would progress to a very severe, or maybe, would have a ductal dependent kind of situation. As a policy, in all these patients where I suspect that something could go wrong, we generally call the patient preterm for a repeat echo. It is difficult because of the bony shadows, but still, we would have to have an assessment that what are we going to expect in the immediate neonatal period, and we generally don't charge for that. So that's another thing which is helpful. We have a pediatric cardiologist from PGI, Dr. Rohit Manoj, and I'm going to ask him the main questions that he's going to answer all those things to us. The questions are, when do I refer the child? Once the child is born, I'm counseling. So I need to tell my parents, okay, in TOF, generally, this is the time frame when I need to refer the child for surgery so that they don't miss that time. And what are the children which may require a BT shunt even in today's time? In India, cost is again a very important thing because it is, there's no healthcare facility, we actually pay for our own health. So what are the costs involved, and what are the parameters which we can pick up on fetal echo, which we can do it on a neonatal echo, which is going to tell me, okay, this child is not going to do well even after the surgery is done, particularly when we do a patch repair of the pulmonary stenosis. Dr. Rohit Manoj, please.
Good evening, everyone. Thank you for a kind invitation for wonderful symposium on fetal anomalies. I think I would, if I see a child fetus with a tetralogy fellow, I'll probably interpret it as a spectrum of disease. It's a typical classical tetralogy fellow. We all know that some of them can be pink, a large number of them are blue. They don't trouble us very immediately. So typical tetralogy fellow don't trouble us immediately, and I wouldn't be too worried about it unless, and I would request the physician or family to saturation. And in our center, we tend to do intracardiac repair beyond 5 kilos, but we don't operate in a 3 kilo, 4 kilo. But there are good centers who are quite comfortable in as early as 3 months on operation also. So surgery is fairly good outcome. And the bad features are, when we say we diagnose TOF, we are not sure it will only turn out to be TOF only. So I think pulmonary artery size is a critical determinant of the when child will require a surgery. So if the pulmonary arteries are very small, he may simply turn out to be very small pulmonary artery, or he may actually turn out to be pulmonary atresia. That we will not know unless the baby is delivered. So all the tetralogy fellow, if I see, I would, if the pulmonary artery size is really small, I'll probably counsel them to deliver in a hospital where the facilities available, may require PG1 or may require a neonatal stenting. As far as when pulmonary arteries are very small, in our center, the pulmonary arteries are very small and a child is below 5 kilo, we still perform either PDA stenting or the BT shunt, whichever is the convenient and feasible based on the cardiologist's preference. So there is a BT shunt is still performed, or we still perform the PDA stenting, that's feasible. The general outcome for the VSC tetralogy fellow is fairly good, and the VSC pulmonary atresia, the outcome is not very good. And although we do operate, it depends on when the child presents. So MAPCAs are very important to determine the long-term outcomes. So that's a complicated surgery, and I will counsel the family that it will require multiple surgeries.
Wonderful, sir. But I think we have an audience which is more of.
As far as the cost, sorry, just cost is concerned. All the 3 states we cover around Himachal, Punjab, and Haryana, they if you belong to the government employee, or if your child is studying in government schools, all the states are covering the financing. So there are no, we don't find much difficulty in the finances are concerned. General cost in our center would be vary between 1 to 1.5 lakh for tetralogy fellow.
Perfect, sir. But we have a group of people, those who are radiologists and gynecologists, and I think let me try to explain them what we do in this surgery. The surgery is that we actually close a VSD with a patch, and we try to put a patch or a repair of the pulmonary stenosis. And
I think we lost your screen share.
Pardon?
I think we lost your screen share.
Really? I think so. Okay.
Yeah. If you could just share it again.
Again. Okay. That's why the things were not working. All right.
Yeah.
So do you want me to start the panel discussion from beginning or from here?
No. We lost only a minute ago. So just your roundup remarks.
I'm just joking, sir. Right. All right. So that's what we do, is that we put a pericardial patch, or and the whole idea here these days is to save a pulmonary annulus or a valve, because if you get a pulmonary regurgitation, and over a period of time you would get an RV dysfunction, and second surgery would be kind of inevitable. So that is what we do in a BT shunt. We many a times when we can't do a proper surgery and we have a small pulmonary arteries, and we provide a BT shunt, that is a shunt between subclavian artery, aortic shunt, and one of the pulmonary arteries. And by this, what we do is that we supply the pulmonary artery with an arterial blood, and this tends to make pulmonary arteries nicer. They tend to grow as the flow is there and we wait till the time patient is suitable for surgery. Sir, I want to ask you, do we entertain the questions right here or the end of the panel discussion? So we've done with first
what
case.
we'll do is we have some very nice simple questions, and if I could, I've sort of summarized.
Let's do that right now. Yes.
Yes, and because we're not sure how many topics we're going to be able to include, we might run short of time at the end.
Yeah.
And the first question which we had was from Hiren, and he wanted to know, how do I measure override percentage in tetralogy of Fallow? So if someone could tell us, how do we measure the override percentage in tetralogy of Fallow?
So if Dr. Orhan is around, because otherwise I'll answer that. As Dr. Orhan has already explained, the override might look different in different views. You know, one view is a lateral four-chamber view, and from there, if you get an LVOT view, which is kind of a parasternal view, what we get in adult cardiology, and there the override may look a little more. But the best place to actually see the override, the percentage of override, when you are in four-chamber view, an apical four-chamber view, and then you go to a apical five-chamber view, and or apical LVOT view, and this is where the septum is right and in say around 11 o'clock or 12 o'clock position, and there you see what is an override of the aorta. If the override is more than 50%, that means it is predominantly coming from a right ventricle, and you have a mitral aortic discontinuity, then you might call it a DORV. But fortunately, if you make 60% or 40%, the DORV of this kind, the management is almost the same. So you know you're not lost. So you don't do nothing to worry that okay, I made it DORV. Once you are writing the report, you know suddenly report changes from tetralogy of fellows to DORV by just percentage, and they're actually the same, and the management is not very different.
Can I just show something? Is it?
Yes. We were waiting for you.
One thing I'd like to stop others. So if I show you this one, perhaps might answer one of the question. What I would like to warn everybody about, this is how we measure aortic override from five-chamber view. You draw a line from the tip of the ventricular septum to the right wall of the aorta, to the left wall of aorta, and then direct line from the tip of the septal axis, and it will tell you how much override there is. So that's how you define. It's beautifully explained in many times by our pathologist, Bob Anderson. I follow his instructions, so that's what we do. I'd like to ask you one thing to pay attention. On two cases, we had terrible problems in patients with double outlet right ventricle. I would definitely advise you to look at the size of mitral valve and also size of left ventricle, because in those cases, it's really difficult if the left ventricle didn't grow. If the mitral valve didn't grow, you cannot offer these patients total repair, and it becomes impossible even to offer any other surgeries. So in double outlet right ventricle, pay attention to the left-sided inlet valve and the growth of the left ventricle. It happened in two cases, and we had horrendous problems, and the operation was not possible. Does it answer the question of override measurement?
Yes, and it answers a lot of our other questions as well. And so if we move on to our next question, for assessing the size of the pulmonary artery, actual measurements or Z-scores?
Is a question to me or?
Yes, yes, the question is for you.
Well, there are two type of branch pulmonary artery measurements. I don't know what my Indian colleagues would do. Manoj perhaps could tell something. Dr. Singh can tell something. Nakata index is one of them. So Nakata index. The other one is easier one to do. You look at the size of branch pulmonary arteries and measure it with the size of descending aorta. The main pulmonary artery should be same size as descending aorta, and branch pulmonary arteries should not be less than half of the descending aorta. What we say month-wise, if the baby is born, if the branch pulmonary arteries are about, so baby is 3.5 kilogram. If they are 3.5 kilogram, there is a hope. Anything over 5 is excellent at birth. That's how we define it. And when baby reaches 4 kilogram, it should be 4 millimeters. Branch pulmonary arteries shouldn't be less than 4. 5 kilograms should be 5 millimeters. If it is less than 5 millimeters, things are not moving in the right direction. That's what we follow. But if you want to be more scientific, you can go to Nakata index and make complicated measurements. But this is more practical in my view. What do you think, Manoj?
I think we are quite happy to see pulmonary artery size of, if you measure, it's about 1.5 times or combination of right and left pulmonary artery is 1.5 times raised to descending aorta. Should we our surgeons are quite happy with that. That's simpler measurement, correct?
Excellent. Good, good.
Thank you. And the last question in this one, yes, Adi, you were going to add something.
Prof, do you do Z-scores in your routine practice?
Well, it's coming now, becoming more and more. Now, our surgeons are reluctant to accept patients if we don't do Z-scores. I think your machine is capable of doing it. Many machines are capable of doing it. Yes, we are looking at, especially in fetal life as well. We started doing it more often now, because that has quite significant prognostical information for us.
Thank you.
Professor, in fetal cardiology, would you prefer these scores more because the errors in measurement could be difficult rather than your visual assessment? For pediatric or neonatal, I think I agree with you, because Z scores are very important, because if the child grows, you know that, okay, the Z score tells you that the growth is fine or not. But what about, fetal cardiology?
I mean, with the machines you guys have, I think you should be perfectly be able to do that. It is difficult if the subject is not very good, image quality is not very good, but it's been validated, it's been developed beautifully. And I sent some Excel sheets to Adi. It's available offline as well as online. And it's easy to do, Dr. Singh. And when baby reaches 26, 28 kilogram, it becomes pretty reliable. But around 19, 20 weeks, yes, you may be right. So therefore, margin of error, call patient back in 4 weeks, 6 weeks time. If the progress is good, then you measured the correct number. If you're not, then go back and do offline assessment.
Yeah, there is a good resource online and the app parameters.com or parameters. So I think that is what you can actually readily open up when you don't have the machine which gives you that information, and would be helpful. Sir.
We did develop some it's called PED-Z, PED in brackets Z. I asked the guy to develop fetal, and I sent all the documents to him. He put some. I asked him to put more, but he did not actually add all the parameters. Only dimensions are available: LV size, RV size, bits and bobs. That's freely available, I think, PED-Z. But the guy promised to develop further. Perhaps if a message goes from you guys too, and he will feel compelled to do it.
Thank you. And I guess we can conclude this case and then move on to the next cases with reminding everyone that there really is no such thing as an isolated diagnosis. We need our machine settings. We need a keen eye for whoever is assessing the fetal heart. We cannot afford to forget the associated abnormalities, and we have to have a correlation with a fetal and a pediatric cardiologist and perhaps a pediatric cardiology surgeon. And without genetics, we really can't move ahead. Dr. Singh, would you agree with me as a summary on this bit?
Absolutely, sir. And we've already crossed the time, but in case nobody is willing to have dinner today, and Professor also is with us for the 2.5 hours movie, then we can go ahead with the second case.
I think so. We'll do one more, certainly.
Yeah, we'll do one more. All right. The case 2, I think I'll now try to be brief on this, and let's have more discussion than this. The problem is that you have a abnormal 3-vessel view where you get just 2 vessels and the third one is missing. And that's how the patient was referred for a fetal echo scan. And if I may show the videos around 18 weeks of gestation, and it shows you, LV with one vessel coming out of it and RV with another vessel coming, and both the vessels are parallel to each other. To further elaborate, you have the branch coming from the LV is branching, the artery is branching, and this should be a very good clue for transposition of great arteries. And the artery which is anterior coming from the RV is not branching and is arching high towards cranially. So that's another clue. Apart from that, which I think would be very, very important to see, that we have what we call as an out of phase flow in the VSD. And let me show if I can tell you what I meant by this is, both arteries are in systole, they are in phase. And in one of the phases in between, when you don't see any color around, now you see this blue color, right? So this indicates that this dropout, what you saw, I'll run it again, is a true VSD and not a dropout. So same thing, you can see a branching artery. And if I move ahead, you can see the artery which is arching above cranially coming from RV. And we would discuss the significance of our lucky finding, that is a VSD. VSD, if I tell somebody is a lucky finding in TGA. Well, let's discuss that. And I'll request Professor to kindly elaborate on how we image a patient with the transposition of great arteries. If you can hear, there is some marriage party going on alongside, so you can hear some bhangra music. I don't know whether you can appreciate that on this mic. Anyway. All right, sir.
I can hear. So let me just shut the door because noise coming from outside. So imaging transposition is, I think, probably delight for fetal cardiologists to do, as well as perinatologists. The main issue with transposition, depending on the orientation of the great vessels, the one tip I would offer to my colleagues and the audience here, if the great vessel orientation is anterior posterior, then certain views are not going to be helpful. If it is side by side, then you may be able to get nice views from long axis view, 5-chamber view, and so on. But if they are side by side, then you will have difficulty. You need to go to sagittal view to show them if they are anterior posterior view. So that orientation is the main obstacle. So maybe various forms. One attention you need to pay. But the usual scenario is to demonstrate parallel vessels. The one coming from the left ventricle has mitral continuity and branches out, which is the pulmonary artery. And the one coming from the anterior ventricle, the one does not bifurcate, but gives off head and neck vessels from its top surface. And that is the essence of it. When it comes to elaborating on the associated pathologies, then you need to perhaps interrogate short axis view. You need to interrogate sagittal view, because 10% of patients with transposition can have interruption or coarctation. Particularly the interruption is disastrous if you miss it. The other thing, VSTs, because that would be lifeline for the baby. If there is a large VST, then baby won't be so much in trouble after birth, won't be duct dependent. Half of transpositions, as you said, has other abnormalities. Majority will be VST. LVO2 obstruction, which is pulmonary stenosis, what will become aortic obstruction. That is the much feared association. If there is aortic stenosis, well, pulmonary stenosis, but will become aortic stenosis, LVO2 obstruction, then two pump repair becomes a little difficult. That is something for you guys to look very, very carefully. That will affect your counseling and prognostication, of course. Multiple VSTs can occur. It happened when the surgeon closed the perimembranous VST. The other one became obvious, and baby had to go back to theater. So look for the apical ones from short axis view of the LV. Go high parasternal, get the short axis of the LV, or from four chamber view, go all the way to the apex, or from long axis view, go all the way to the apex. So the apical VSTs must be excluded. I would ask you to look at it. Heterotaxy is in simple transposition. We have never seen heterotaxy in simple transposition. Genetic abnormalities, again, we have never seen in simple transposition. But the most important one, as I said, LVO2 obstruction, interruption, coarctation, and additional VST. I think those are the ones I pay a lot of attention. When you go up, higher up to the parasternal short axis view, higher up, and obtain sort of round view of arterial valves, sometime you may be lucky at 32 weeks or 28 weeks to see whether aortic valve is bicuspid or pulmonary valve bicuspid. So that might also help you whether this baby is going to develop further pathologies. Coronary arteries, I think with the machines you have, you are producing remarkable images. I mean, I admire you guys. I follow you. You're fantastic. Coronary arteries, I think, can be seen in fetal life. And if you can comment on that, you would look very smart. I think pediatric cardiologists would be very jealous. And I trust Indian perinatologists. You are amazing. You can look at it. Short axis view, very helpful. Again, long axis view is very, very helpful to demonstrate coronary artery pathology. If you can show that. Does it affect postnatal intervention? In some of them, but even postnatal echocardiogram may not be good enough. So you may need to do additional imaging modalities. We have to admit sometime our limitations. That's all I would like to say.
Now, I think tetralogy of fellows is really, sorry, TGA is, the pickup rate was quite low, and we all understand the reasons were that it is difficult many a time to see the branching of the artery, and we miss the crossover many a times, and that's why pickup rates were quite low in the beginning. We are actually improving on our views these days. And I'll ask Dr. Adi that what are the extra cardiac abnormalities with this, and what are the differential diagnosis we have in case we have a single vessel. Let's go back rather than saying that you have a patient of a transposition of great arteries. Let us ask this question that, yes, please, sir.
Can I interject?
Please.
Three-vessel trachea view made a great difference in the detection of rate of transposition in the UK. If you go to NICOR website, NICOR-CCAD, you can all access, and you can see the pickup rates in Britain, and in each hospital is listed, and each nation is also listed. And the pickup rate in Wales now 100%. Transposition 100% in Wales. We have not missed any transposition for the past few years. When you look at that list, the lowest number is now 75% after we implemented three-vessel trachea view. Simple sort of orientation of aorta becoming anterior in relation to the pulmonary artery made a huge impact. So this can be seen on NICOR. I would advise people to pay more attention to three-vessel trachea view for transposition.
Yeah, Dr. Adi, please. Dr. Adi?
You're doing pretty good for a while. Adi, you need to unmute yourself. You're on Brigade Gateway now. Yes, so can you please unmute? Let me try and unmute you. There you are.
Yeah, there you are. Thank you. Sorry, my internet got messed up. Answer to UP Singh's, Dr. UP Singh question. If you see two vessels in a three-vessel view, what are the differentials? And before that, and the diagnosis of transposition of great arteries is vastly improved after we saying the outflow tracts views. I tell my fellows, there is no way you can miss one case of TGA in your life. If you are following a religiously segmental systematic analysis, and if you can get three-vessel like PAS, anterior, middle, and posterior, you will not miss a tetralogy. Because in tetralogy, however, you don't miss a transposition. In transposition, whatever you did, you will not get a normal three-vessel view. So that's my for you to take home. When you see only two vessels in three-vessel trachea view, either one vessel, great vessel, is atretic, or it is not in the plane. And if it is atretic, it may be an aortic atresia or a pulmonary atresia or intrapedaortic arch. And if it is outer plane, it can be a transposition, because the pulmonary artery, which arises anteriorly, goes posteriorly and inferiorly, now is displaced downwards, and aorta is displaced anteriorly and towards the right. So you will never get two vessels at a one strict axial view. So it can be a detransposition or congenitally corrected transposition, or it can be double outlet, where it is the two great vessels are next to each other, or like a side-by-side arrangement or a transposition arrangement. So these are the two main differential way to think of.
Perfect. I think sir has a control of mute and unmute, and I wish I have that in the family discussions, but I don't have that liberty. Okay. Now there are hardly any extra cardiac. I come back to Dr. Divya again from radiologist, or from a point of view that you just let us know what are the difficulties in TGA diagnosis and how should we improve upon that?
The challenges in diagnosis of transposition of great arteries arise from the fact that many of the times this is just an isolated finding, and there is not some other red flag which would catch our eye and prompt us to look at things more carefully. As you know, there are hardly any extra cardiac findings, and 50% cases with TGA do not have any other additional cardiac findings as well. In addition, the size and the vessel caliber is again not that conspicuous to catch our eye, which can also result in a misdiagnosis. And the classic parallel orientation of the great arteries that we look for is not seen in our traditional screening views and requires little angled views, as Professor alluded to, and hence may be missed. Another thing is that if we go for the 3-vessel view, we might see the 3 vessels in the 3-vessel view. But remember, the 3-vessel trachea view is the most cranial of the fetal screening planes. And this includes from left to right, the ductal arch, the aortic arch, and the superior vena cava. And it is this 3-vessel trachea view, which is particularly helpful in screening for TGA, because what we see are just 2 vessels in case of transposition, the aortic arch and the superior vena cava, while the pulmonary artery tends to lie beneath it and is not seen in the 3-vessel trachea view. So this is, if we follow 2 views, that is the 3-vessel trachea view as well as the left ventricular outflow tract view, we can increase our pickup rates of transposition of great arteries. In the left ventricular outflow tract view, we should not just stop at focusing at the septo-aortic continuity and the aortic valve. We should try to trace the vessel further on to see that it's not bifurcating and hence it's not a pulmonary artery. That would be all, sir.
Yeah. I think that's very good. That's very good. And we now come back to Dr. Meenakshi, and I think we thought that we don't have a great role in TGA of a geneticist, but you're going to enlighten us.
Thanks, sir. So until a few years ago, we all thought that, TGA isolated, and because we know with TGA, the extracardiac anomalies are not there. So we all know, so there is not much of a genetic association. But now there recently, the isolated case reports and series have come up. So now they say that there are meta-analysis which say that there is a 4% association of chromosomal, but these are very sporadic reports. But I would be still saying that chromosomal without extracardiac in TGA still might not play a very important role. So isolated TGA, I would be comfortable if we do not routinely prescribe microarray. In heterotexy, if there is TGA with heterotexy, we usually don't see chromosomal hair, so there is no role of ordering a microarray in such cases and going for amniocentesis. But if the heterotexy, there have been case reports and literature is there now, if there is reoccurrence of heterotexy or there's a clustering, there is certain mutations in the ciliary genes which lead to formation and migration. And so in these, there are various genes like the ZIC2 genes, the Notch genes, which have been found mutated. So these can be tested, but before going on to all such bigger testings, we need to do a good amount of prenatal counseling of these patients. Even the doctors need to be informed. So, and in the list, we see bacterial charge, tuberous sclerosis. These are all very isolated cases, so not routine. Routinely for TGA, I would say the red flag would be if extracardiac, which are very, very few, rarely kidney and cerebral are found. And with the extracardiac also, you have to build up a phenotype, and then that phenotype will tell us either you go for a microarray or NGS. So that phenotype building is to be there. And the risk of reoccurrence definitely depends upon the prognosis, because chromosomal usually do not reoccur. If there is a heterotexy with TGA and it reoccurs, I would go for NGS. And usually it would be safe to say to your patients, it is a sporadic abnormality and it will not likely reoccur. Chromosomal association most likely will not be there, but exceptions are definitely there that needs to be counseled. And if there is heterotexy, you will not find chromosomal, but single gene etiologies. And that the purpose in testing will only be there if there's a reoccurrence. And empirical risk of reoccurrence in TGA is the least of all, because the genetic component is the least, it is 1.7%. So that would be all from my side.
Thank you. I think we move on quickly to Dr. Manish Tomar so that she can enlighten us. This is the condition where we want the child to be delivered in a tertiary care unit, and Dr. Manish to be in charge of that baby as the baby is born. So please enlighten us that are there, how should we go about delivering the child?
Like TGA means complete transposition of great vessel, that is DTGA, which is the going to create issues in neonatal period. Depending on the scenario, like one is TGA with intact ventricular septum with interatrial communication, which is small. If we are expecting a small communication, means not a sufficient ASD in fetal echo. That we follow fetal echo is very important. Then we need to plan with a place where we have a cardiac facility, because these baby may require septostomy, may require prostaglandin infusion. Term deliveries, anyone would like to have a term delivery with vaginal or cesarean depending on the obstetrician indication. So there is no specific indication for LSCS. For after birth, this baby, newborn baby with intact ventricular septum, in today's scenario, we give, if we can buy 2-3 days, we go for direct arterial switch operation. Usually we avoid to go extra intervention like balloon atrial septostomy, which we used to do very commonly in previous few years ago. Now we try to go for the septostomy, but while buying these 2-3 days, the baby general maintenance means temperature, fluid, electrolytes, asepsis care, prostaglandin should be there in an ICU, ventilator care should be standby there. So everything has to be ready. If saturation is above 75%, baby is not acidotic, we go for directly for the arterial switch operation. If these things are getting worse, means he's getting acidosis, he's getting severely desaturated, you go for the septostomy or prostaglandin. Like it's a teamwork, surgeon and the among the surgeon and the cardiologist to take a call as early as we can go for the switch or septostomy to stabilize the baby. When there is VSD, so with VSD, you are comfortable that LV is not going to regress, child is not going to immediately desaturate in the to that low level, 70-65%. But the thing with VSD is, after a few days, means 3rd, 4th day of life, when pulmonary vascular resistance is falling, increased pulmonary venous return. So if atrial communication is small, again, though VSD is big, but atrial communication is important here. So if interatrial communication is small, there is VSD, we are going to operate at 3-4 weeks of life, you need to go for the septostomy to release the left atrial pressure. In addition, your general care, temperature, fluid, electrolytes, everything need to be balanced, need to be taken care of, proper asepsis. You need to look at the interatrial communication, you need to look at the acidosis. So again, things should be checked. It's VSD is there, we can't sit comfortably. Overall picture is important. Sometimes even with VSD, we have to go for early surgery. Usually with VSD, we get few weeks for the life. In some babies, we need to go for septostomy and VSD also. The third group is TGA, VSD, pulmonary stenosis. So that you expect to present like a tetralogy or Fowler situation, but they are very blue. Here again, you need interatrial communication. With transposition physiology, interatrial communication is so important. If you are not going for total correction, you are going to buy some time, your interatrial communication for good mixing, for better saturation is needed. So overall picture depend on VSD is there, how critical PS is, depending on that, where you need to go either for the BT shunt to improve the saturation. If interatrial, if your VSD is there, integrate flow is good, shunt will not work. You need to look at the interatrial communication. If it is small, you increase that and your child will be better to buy time to go for the total correction, because they are going to have a conduit, which is an artificial tube. So you will like to have at least a year, 6 months to a year to put that artificial tube. So depending on the anatomy, you will plan your things in immediate neonatal period. Internatal combination is very important TG physiology. And another important point is just when we are discussing about the echo, rarely TGA can have normally related great vessels. So relation is important. We are seeing two circle, we are seeing this and that, but normally related great vessel in TGA, in a special relationship, will create a confusion. So you need to follow the vessel. Pulmonary artery to bifurcation, aorta to aortic arch, and the descending. We need to follow in all patients because we know we have fooled once with normal related great vessels and it was TGA to get after birth.
I think that's very good. The carry home message, may I sum up from you that anyway, the child has to be referred to a pediatric cardiologist in case we are so sure about a VSD, then maybe after a week. If we we are not sure about the VSD and we don't have a VSD, then the delivery has to be done in a tertiary care unit. So anyway, you have a margin of 7 days, whichever way we do it. We have our last panelist, Dr. Rohit Manoj, who would guide us. Again, the same set of questions I have for him, and then probably we wind up. When I think the kind of partly answered already, when do we refer for surgery? What type of surgery? You know, there are a couple of physiological and non-physiological surgeries. I mean, if I am to kind of counsel the patient, then what should I tell them? And again, the cost always comes, and what are the outcome parameters? Dr. Rohit Manoj, please.
I think Munish has covered a lot of things in my talk. I'll probably say that a baby has to be born in a hospital. I wouldn't take a risk of delivering the baby outside the hospital. That needs to give message needs to be given to the gynecologist or obstetrician who are looking after the, or perinatologist who is looking after the first message. Baby has to be delivered in a hospital. And as she said, septostomy is a crucial thing. We need to assess, is the ASD good or not? That needs to be assessed. A lot of centers now are avoiding septostomy and going straight away with the prostaglandin infusion and surgery in few days. As he said, typical or ideal surgery, ideal parent want the best. Every parents want the best for their children, and a best surgery is arterial switch surgery. Sometimes it's not feasible to do arterial surgery, like late presentation, which happens in our setup, Indian thing. Then regression of the LV or late presentation, or then we think of atrial switch. But then that's not the ideal thing. It also has it gives fairly good palliation, but not it has a lot of difficulties are there. And imaging coronary arteries, in our surgeons don't ask for coronary. They don't ask me where is the coronary artery. They don't bother about it. They will anyway find out and operate it. So I don't scratch my head. It's nice to know the coronary arteries, but our surgeons are, they don't trouble me for coronary arteries. And cost is depends on center to center where you operate it. And I would say a lot of perinatologists will ask me, TG is there, I want to terminate. It's not a good thing. It's in good center, the outcome is very good. The survival is good, long-term outcome is very good, well documented. So the mere presence of TGA should not make us to team to say terminate the babies. We should continue them, and very good outcome. The only problem is that presentation. If you have a late presentation, even the some of the subaortic pulmonary stenosis, or what is a pulmonary stenosis, some of them, large number of them have only infundibulous stenosis, not valvular stenosis. So that can be resected and switch can still be done, right? Or of course, some delayed presentation like AIMS does, we can do PA banding and train the ventricle and do. I would personally, I'm in favor of not aborting. A lot of questions they ask me, shall we abort the baby? Not the. I would like to give a message that it is a fairly good outcome. Thank you for kind of opportunity.
That was fantastic. And back to Dr. UP Singh again for. We can't hear you, Dr. UP Singh. We don't see you muted, but we can't seem to hear you. Maybe I'm going to mute and unmute you automatically.
All right. So I think we are juggling between, I'm also. So, sir, I think if we have questions, maybe we can take it, and we've already exceeded the time, right?
Yes, and we've actually answered most of our questions.
Right.
And I think it's time for closing our session and thanking all our participants today.
Thank you.
So I think that's been wonderful, and picture abhi baki hai mere dost. Maybe we can continue sometime later.
In the future, certainly, yes.
Yes, sir. And thanks to you, sir, because you would orchestrated everything to this level, and thought of doing a pediatric cardiology and fetal heart to touch it in this time. And it's with Professor, it was fabulous discussion amongst all our, and I thank all my colleagues, panelists, for contributing wonderfully and spending time and making things so lucid for our delegates. So thank you. Have a good time. Be safe in COVID, and second, third waves are all there. Vaccine is also. Save yourself for the vaccine.
Wonderful. Thank you. And
Thank you.
Remember that having COVID is not a good thing. Post-COVID things are very, very common. Post-COVID coronary artery disease, post-COVID pulmonary stenosis, pulmonary fibrosis is very common, and we do not know anything about that, what is going to do in future. So save yourself for the vaccine.
thank you. And I'd like to take this chance to thank everyone who's been on this program today, apart from, of course, our back end and, of course, Vishal Mittal from the head office. Thank you, Ladbans, for putting all this together. And when I was Googling, and I was wondering, what do I say about Professor Uzun? And I came across something very nice. And in his last name, the UZUN, someone said U for unique, Z for his zeal for teaching, U again for useful for so many humans who wish to learn, and for the lives he keeps saving because he teaches us how to do things correctly, and the N in the Uzun for nice to everybody, including us. Thank you, Professor, for sparing your time. And thank you, everyone here today, for being here and for teaching and for learning. Good night.
Good night. Good night. Thank you,
Good
sir.
night. Good night.
Good night.